Welcome to 2021 Midwest Radiation Oncology Symposium. My name is Ken Zim, radiation oncologist here at University of Nebraska College of Medicine. Our session, I'll be moderating this session, oral cancer. So we're going to divide this into three parts. The first part is more like a practical aspect, how we practice the surgery, radiation, and also this management of dysphagia post-therapy. The second part is more clinical research looking for a possible biomarker. And the third part will be given by Dr. Batra, looking into molecular biology, potential way to improve or sensitize radiation, improve treatment outcome in head and neck cancer. So without further ado, I'd like to introduce Dr. Bradford Bell, who is assistant professor otolaryngology head and neck surgery at UNMC. Dr. Bell will be talking reconstructive perspective for oral cancer. Dr. Bell.
Thank you, Dr. Zen. Let me go ahead and share my screen here. All right, can everyone see that okay?
Yes.
Excellent. So as Dr. Zen mentioned, my focus is going to be on oral cavity, primarily oral cavity reconstruction following primary surgical resection. I'm one of now 2 head and neck microvascular surgeons here at UNMC. So the objectives for today's talk are going to be just to review the role for surgery and treatment of these cancers, discuss the indications for reconstruction after the primary ablative resection, and then to review the outcomes and some of the complications that we have to take into consideration with reconstructive surgery for these patients. So just to define the limitations of the oral cavity to get started here, we really think about the oral cavity extending from the wet or mucosal lip posterior to the junction of the hard and soft palate. And then also between the junction of the anterior 2/3 of the tongue, which we can see here, and the posterior 1/3 of the tongue or the base of tongue. So really everything you can see in these pictures are the subsites that are included within oral cavity. It is all of the tooth-bearing bone segments of both the maxilla and the mandible, the associated gingiva, the floor of mouth mucosa, which is the mucosa underlying the tongue, the oral tongue itself, as well as the buccal mucosa, and of course the wet lip. So these are kind of, high value real estate from a functional perspective from both speech and swallow, and I won't belabor this point. I know Carol Gabler will be giving us a wonderful talk on this upcoming. So just to make the point that really we have to have all of these subsites sort of in continuity and some sort of functional capacity for patients to be able to speak and swallow efficiently. So when we think of the lips, the primary importance is that they form a seal to allow us to build pressure within the oral cavity. We have our teeth to help grind food mechanically. It's driven by the muscles of mastication, which these can both be affected by surgical resection. And we really rely on our tongue, both mobility and propulsive effects from the motor input of the tongue that we have to take into account. And certainly all of this can be affected by the integrity of the palate. We really need a nice separation between the oral cavity space and the nasal cavity space, which is the primary function of the hard palate. So with that in mind, all of these subsites function both based on bulk, the volume of the structure itself, the surface area that they take up within the mouth, and then also the mobility. So both motor function, but potential for scarring and tethering of these structures postoperatively. And a lot of this is driven by both the motor innervation as well as the sensory activity from the second and third branch of the trigeminal nerve, as well as the hypoglossal nerve. And so we're either removing the primary or end motor targets or sensory targets for these nerves, or we're cutting these nerves directly during the surgical excision. And the reason that we really talk about surgery so much with oral cavity is that this is the first line of treatment recommended by the NCCN. And we're pretty much offering surgical resection for all patients of all T stages, unless they're deemed surgically unresectable. So we consider surgical unresectability in patients who have internal carotid artery involvement or encasement, typically more than 270 degrees around the internal carotid artery. If patients have prevertebral fascial involvement or vertebral artery artery involvement, and really specifically to the oral cavity, masticator space involvement. And I put an asterisk here because this is really kind of a relative contraindication. We can certainly remove very large buccal space tumors and get negative margins, but whenever tumors are creeping posterior along the maxilla, when they're involving the pterygoids, it can be a lot harder to primarily clear the disease at the initial time of surgery. So this is sort of a relative contraindication for us. And of course, patients who are elderly, debilitated, overall poor surgical candidates for other reasons. So it's the tables from the most recent update to the NCCN. Essentially all T1 through T4A patients, including essentially all of the nodal stages, excluding those patients that I just mentioned. And the only other thing I didn't mention on the previous slide is patients who have metastatic disease, we consider those a little bit differently. So all of the early stages, the later stages, surgery is really the preferred treatment modality. And this is a bit different than the other subsites within head and neck cancer that we treat and manage. So for each subsite, with the tongue, we can remove part of the tongue. We can do a total glossectomy and remove all of the tongue. We can remove the tissue of the floor of mouth, that lining under the tongue. We can essentially resect all of the buccal mucosa, the buccal space. We can remove the maxilla. We can remove the palate with that. We can remove segments of the mandible. And oftentimes, if we're removing one part of the tongue, we might also be removing some floor of mouth. If we remove some of the buccal space, we might also be performing a small limited maxillectomy or a mandibulectomy. So typically, we're working on multiple subsites at the time of the ablative surgery. And very often, we're doing a neck dissection to either treat radiographically concerning nodes, clinically palpable nodes, or as a prophylactic approach to sample the lymph nodes in the cervical chain to better prognosticate and stage the patients, and as a therapeutic intervention just to clear these nodal basins with surgery. This, of note, whenever we're doing a neck dissection and we're working on the oral cavity, typically creates a communication between the oral cavity and the neck that we have to consider when we're considering reconstruction options. So for me, from a reconstructive perspective, I'm thinking about the functional restoration of the patient. So I have to rebuild volume that's lost, the bulk of the tissue that was removed. I have to think about the surface area, how much was removed, how am I going to rebuild that? There's some potential sensory considerations, and this is an active area of research that I'll touch on later in the presentation. And then radiation therapy postoperatively. Any patient that we see who has an oral cavity primary, who has positive lymph nodes in the cervical stations, I know that these patients are going to be recommended to undergo radiation therapy. This is a big factor that I take into thorough consideration whenever I'm planning reconstruction options for these patients. I want something that's going to be able to withstand radiation well for the patients. And most reconstructive surgeons will work through the reconstructive ladder. And this is essentially a way to just kind of think about different options for reconstructing a defect. And it starts on the bottom rung with the most simple option, which is primary closure. And as you work your way up, you can let things close by secondary intention. They just kind of granulate and heal in. You can use wound vacs. You can use skin grafts. You can use dermal matrices from the lab. Local or distant flaps where you're not actually dividing a blood source, you're just sort of rotating, lifting and rotating tissue in. You can use tissue expanders, although not so much in the oral cavity. And then the top echelon of the reconstructive ladder is free flap or free tissue reconstruction. And the basis of free tissue reconstruction is that you're literally transplanting a segment of tissue, whether it's skin, fat, muscle, bone, a combination of all four of these, from a distant area of the body to the head and neck. So you're obtaining this tissue, you're harvesting it. You're also harvesting both an artery and a vein with this tissue that you have to sew into the neck to allow adequate blood supply to the component of tissue that you're transplanting. We have donor sites on the forearms, on the thigh, on the lower extremities of the calf. We can use abdominal skin. We can use the scapular system. So we essentially have donor sites all over the body, which is nice because some patients have pre-existing conditions that preclude you from using one site as compared to another. So we have lots of options to work with. And the length of surgery for these patients, so if we always do the ablative portion where we're removing the tumor and the reconstructive portion in one setting in the operating room. And this can be anywhere from 6 to 14 hours under general anesthesia. So this is certainly a big resource intensive procedure where we're in an operating room all day. We use 2 surgeons to perform this procedure. So my partner will do the ablative portion. I'll do the reconstructive portion, which just helps with surgeon fatigue. We have 2 sets of nurses nurses, 2 sets of scrub techs for all of these procedures. And it requires some specialized equipment. So I mentioned we have to sew these blood vessels into recipient blood vessels in the neck. So I use a microscope for that. And part of the reason is that the blood vessels that I'm working with are anywhere from 1 millimeter in width to maybe 3 millimeters, maybe 3.5. And I have to use a very, very small caliber suture to do that. So this is just micrograph of this suture here. This is a 9/0 filament. You can see this thread-like suture here. This is the needle attached to it. And this is a human hair. So we're working with very, very small suture. We have to use very small, delicate instruments to perform that part of the surgery. And then these patients also require close postoperative monitoring to ensure the integrity of the blood vessels that are sewn. I send all the patients here to the intensive care unit at least for the first 24 hours, and then they can go out to a step-down unit. Some institutions send people directly to a step-down unit, but here I've had better success with sending people to the intensive care unit just for the nursing ratio. It's really the primary consideration there. So the indications for me for free tissue reconstruction, I mean, this is certainly an undertaking for the patient. They're under general anesthesia for a prolonged period of time. There are a lot of kind of resource utilization considerations here with both the operating room use and just the intensive care unit, as well as post-operative rehabilitation. So I really want to have kind of strict criteria that I'm using. I want to know that my reconstruction is going to be in the best interest of the patient. So I had mentioned earlier radiation therapy. This is one of the primary things that I consider. I want a nice vascularized piece of tissue to reconstruct the defects so that the patient can undergo radiation therapy without delay following surgery. Many of the defects that we deal with within the oral cavity cannot simply be closed primarily. If they can, if we're dealing with a very small like T1 tumor of the oral tongue and it can be closed primarily, that's great. But if it can't, we know that these non-vascularized like tissue matrices, even skin grafts, just do not perform well under radiation. So we want to set the patient up for success for the additional treatment they need to really cure them of their disease. Specifically to the oral tongue, I don't know why this looks like this, but 25% to 30% resection of the tongue, I'm going to consider free tissue reconstruction in that patient. This is a lot of bulk to lose from the tongue, and I want to make sure that their speech and really their swallow is set up to have the best functional outcome by rebuilding both that bulk and surface area. Typically, if we're removing this much tongue, we're also removing some of the floor of mouth mucosa. And with that resection, we have to consider tethering and scarring of the tongue, which limits the mobility of the tongue. So I have to often reconstruct this as well, just so I don't limit the mobility within the oral cavity of the tongue. Buccal space resection, we can take all of the buccal mucosa, and if you were just to close that back on itself or let it heal by secondary intention, you really end up with this terrible soft tissue trismus. I've had to do some secondary reconstructions for patients who were treated elsewhere who didn't have free flaps placed in their buccal mucosa, and they essentially couldn't open their mouth more than 1 millimeter, and it was just a misery for them on a day-to-day basis. So I always reconstruct the buccal mucosa to avoid that issue. The maxilla is an interesting case. So we can remove essentially half of the maxilla. We don't necessarily have to use free tissue to reconstruct this. Patients can use an obturator, which is like a retainer that they kind of pop in there if they have any tooth-bearing segments that can support it. And they take it out each day, they clean it. Some patients really don't want to have to deal with having to take something out and putting something back in and cleaning it, so they opt for free tissue reconstruction, which is also an option. The mandible, if we're removing an entire section of the mandible, almost universally, you need to perform a free tissue reconstruction to reconstitute the continuity of the osseous component of the mandible. So patients just do not do well if you simply put a reconstruction plate on and you don't put any bone under it. They have a high rate of extrusion of the plate following radiation therapy, and just the torsional and kind of load-bearing aspects of chewing and of our mandible use. It's very challenging to get a good reconstruction without actually doing free tissue and bony reconstruction. So this has been my experience. I've been here for 2 years, and this is kind of the breakdown of the flaps that I've done. So the vast majority have been for oral tongue, followed by the mandible, and then buccal mucosa. And if you really look at oral cavity versus all other subsites, 75% of them have been oral cavity reconstructions. And this really just harkens back to the fact that surgery is the primary treatment modality for oral cavity cancers as compared to other subsites where it's not necessarily. So the vast majority of the free flaps we do here are for oral cavity. And these are the kind of defects that I'm walking to the operating room and seeing and dealing with. So, for this patient, it was a very sad case. She was in her 20s. She had gotten pregnant and then had this oral tongue squamous cell carcinoma that was keratinizing, deeply invasive. She had just this horrible progression while she was pregnant. She actually had to have her baby delivered early so that we could take her to the operating room to deal with her cancer. But her tongue was very stuck down. It was hard to access transorally. She had sort of a small, petite mouth. So my partner elected to cut through all the floor of mouth mucosa and dropped the tongue into the neck. So this is actually her oral tongue. Her mandible is up here. Her cervical neck skin has kind of been pulled up over her chin here. Her feet would be on the left side of the screen. This is her larynx. These are the strap muscles overlying the larynx. And this gives us a really great view of the tongue. So he was able to remove essentially 80% of her tongue. And you can imagine that you really can't put a skin graft in here for reconstruction. So these are the types of the defects that we're dealing with that we can successfully reconstruct because we have the option of free flaps and free tissue reconstruction. This is a gentleman I took care of who had this sort of, well, I thought this is acute verrucous carcinoma. I can usually, section that out. I can do some local flaps. He'll do fine. And then looking inside the mouth, he had this buccal mucosal creep, and I realized he'd probably have a through and through defect. And I really don't want him to develop microstomia or trismus from his buccal cavity resection. So I ended up doing a radial forearm free flap reconstruction. There's a little tendon deep to this just to give him a little bit of extra integrity here. He did not need to go undergo radiation following his surgery. So he had a bit of a bulky flap, and he went back for a reduction in his flap, and he was pretty happy with the ultimate outcome here. And it's not uncommon for me to go back and revise flaps in the future, and I'll talk about that a bit later. I'm happy to say this isn't the typical defect that I walk into in the operating room, but this is certainly something that happens and something that we have the ability to reconstruct when it does. So this is a gentleman who, this is obviously his nose, what's left of his lips, his left eye is up here, his ear is here, his feet would be at the bottom of the screen. And he had a left hemimandibulectomy defect, as well as a floor of mouth resection. He had a partial maxillectomy here. All of his buccal mucosa is gone. He had a radical parotid. He lost his facial nerve on this side, and he had a massive external skin defect as well to deal with this huge kind of fungating masticator space tumor. So for him, for his reconstruction, he had a scapular system reconstruction, and he essentially had the internal lining for his cheek was his latissimus dorsi muscle. He then had a scapular border bony reconstruction with a reconstruction plate to recreate his lateral mandible. And then he had a large skin paddle overlying it. And the benefit of the scapular system is that even though I had 3 large kind of robust pieces of tissue that were transplanted, all of these are run off of just one artery and one vein that I had to sew into the neck. So it makes it really nice from that perspective. We don't have to do multiple types of free tissue transfers in one patient. We can use one nice donor site. And he ended up doing very well. I need to put an updated picture in here for him. He's still out there doing well. This is a patient from my fellowship who had essentially the exact same defect as the patient on the previous slide, except he did not lose any of his facial skin. For his approach, because he didn't lose facial skin, we did this massive facial skin flap. So he essentially had this mid-face approach with an upper lip split. He had a lower lip split that connected to a neck dissection incision and then came up in his pre-auricular space here. So this tissue is essentially his entire facial skin kind of flipped up over the forehead. He did not lose his eye, which was lucky for him, but he did lose most of the rest of his maxilla and a segment of his mandible, as well as all of his buccal mucosa and his parotid. And this kind of thickened, meaty appearance this is all scapular reconstructive tissue. So this is the tip of the scapula, which was used to reconstruct his palate. This is the lateral border of the scapula, which you can see affixed to the mandible with the reconstruction plate. And all of this volume of free tissue, muscle, fatty muscle, skin paddle, all of this is driven and powered off of one single arterial anastomosis and one venous anastomosis. And this artery is probably about 2 millimeters in size. So we really can put a lot in there to rebuild and reconstruct and do it with just one single anastomosis. So this patient is very full here as compared to the other side. And this is intentional, and I'll kind of circle back to this. So one of the things that we have to consider whenever we're going to decide whether or not we're going to do a free flap reconstruction is this idea of acute flap loss. So we monitor these patients very closely postoperatively because, again, I mentioned these vessels are very small. They do have a propensity to clot. That's one of the risks. If they clot, you can have ischemia and loss of the free flap. And you put a lot of work into these patients. These patients have undergone a lot of surgery. You want to prevent that and salvage it. if possible. So we have nurses go in and monitor these flaps every hour. Our residents go in every 6 hours for the first 72 hours post-operatively, and either do a skin prick where you just kind of interrogate a skin paddle with a 25 gauge needle to look for bright red bleeding to ensure that we have good oxygenated blood flowing through the flap. I use an implantable Doppler, so I have a small sheath that I place around the artery just to monitor the arterial signal post-operatively, and this is something that just stays implanted in the neck. I start all of my patients on a full dose aspirin. They actually get a rectal aspirin suppository in the operating room before they get transported up to the intensive care unit. And then they start that, and I have them continue that for 30 days. It's a pretty common regimen. There's, to be totally honest, not a lot of great data that supports doing this, but many flap surgeons do that. Maybe just a bit of superstition. I'm not sure. Some people give heparin intraoperatively. I really don't do that unless I have a couple clots that have formed in the artery, in which case I'll give them a bolus of heparin as I'm repairing the vessel. And I always tell patients there's about a 1 out of 10 chance that they're going to need to return to the operating room during their hospitalization. Most of our patients stay in the hospital about 7 days. And I tell them, you might have a hematoma that develops, you might have an issue with your vessels that develop. So you have a 10% chance of going back to the operating room. Our return to OR rate is less than this, but it's nice to just kind of prepare them for that. So then if it happens, they're not particularly surprised. Complete flap loss, where you just have complete necrosis and ischemia of the flap, no matter how many times you revise the vessels, how closely you monitor it. This is extremely uncommon now. So when free flaps were first sort of described in the 80s and then became more and more popularized, the rate of loss was much, much higher. And now, I've only been out of my training for 2 years. I kind of grew up in my training at a time where we did flaps on everyone. It's really because the outcomes have been so good. The risk of complete flap loss in some institutions is less than 1%, up to maybe 3 to 5%. So if you have 1 to 3 patients out of 100 that you're treating with free tissue reconstruction, it's a pretty good outcome. So this really isn't a reason to not do these flaps and these reconstructions. It's not even really something I talk to patients about and I counsel them about, but I don't really consider it if I'm deciding not to do a free flap or how to reconstruct the patient. We can get some partial loss. So patients can get some areas of venous congestion. Patients who have microvascular issues, all these patients are smokers, they can get some patchy loss of tissue, and we can use leech therapy in some instances. So this is a patient who had an external defect, an external reconstruction with a thigh skin flap. You can see this area of kind of darker bruising. This was an area that just had poor venous flow, and so he got leeches for a couple days. You have one leech that's changed every 12 hours with a fresh leech. You usually have to put some sort of barrier around the leech because they try to crawl off to other places to feed. But the nice thing is that they introduce some anticoagulative factors directly into the tissue of the flap, and they also help to decompress the flap just by the nature of feeding on the blood from the skin paddle. Really tough to do this in the oral cavity. You can, but patients have to be sedated and either intubated with a cuffed trach in place or intubated with a cuffed endotracheal tube in place, of course. And then you have to pack off their oropharynx and hypopharynx. You don't want these leeches to migrate, further along the GI tract. So you really have to be cautious and monitor them pretty closely. And it's a little bit tougher in the oral cavity, but it is an option. The other issue that we can run into from a healing perspective, whether it's partial loss of the free tissue transfer or just kind of dieback of the native tissue within the mouth, is fistula formation. So orocutaneous fistulas or orocervical fistulas, where patients have saliva that leaks into the neck. This can be an annoyance, but typically it's something that we can manage locally with packing. I typically have patients go on to start radiation unless they just have a massive fistula or something else going on that's an issue. But small fistulas are not a reason not to kind of continue with treatment, and it's certainly something that can be managed typically conservatively without any additional secondary reconstruction. So I had mentioned, the bulkiness of some of these flaps, and the reason that we kind of overbulk these patients is because we know that 50 to 60% of the muscle is lost just by the simple act of cutting the nerve, the motor nerve that goes to the muscle segments that we're transplanting. You lose all of that kind of trophic factor, and the muscle just naturally kind of goes through this fatty atrophy process. So you can lose about 60% of the volume with muscle, about 30% of volume loss with fat, and really not much surface area loss with skin. Whenever we're thinking about radiation, though, we can have further loss of all three of these. And so I always try to over-reconstruct these patients by about 60%. So I'm putting 60% more volume than what I think the patient actually needs to overcome both of these bullet points. I can always go back in and remove some of the flap in the future. It's really tough to go back in and put more tissue in. So I'd always rather go back in and remove than feel like I didn't put enough in. And I wait at least 3 months post-radiation to do any sort of revision. This is important because it allows us to get their post-treatment imaging and ensure that there's no persistent disease, no distal disease that's developed. It allows for adequate kind of tissue contracture and these processes to play out. Most patients, I will tell you, 3 months after finishing their treatment, they went through a massive surgery, then they went through radiation. And even at 3 months, like I don't want to undergo another surgery right now, which is reasonable. So oftentimes it's kind of further down the road that 6 to 9 months to 12 months later that we're going back and doing revisions for them. So from a functional perspective, tons of studies have looked at free tissue reconstruction and have shown superiority when we're thinking about speech and swallow function in oral cavity for patients who are reconstructed with free tissue versus anything else on the reconstructive ladder. So it's really my first choice for many patients who have medium to large size tumors. The hot area of research right now is innervated reconstruction. So it's a pretty active area of research. We're looking at sensate flaps, innervation of oral tongue reconstruction. And we see that patients do have superior 2-point discrimination compared to non-innervative flaps. But I'll tell you, many of my patients come in and say that their flaps are sensate, and I do not do nerve reinnervation. And I think they get some cutaneous ingrowth of cutaneous nerve fibers. And this hasn't really shown to have a clear benefit for speech and swallow, similar with motor innervation. Certainly down the road, with more research, better techniques, these things could change. So just as a summary to review the teaching points or objectives, this is really the primary treatment for oral cavity malignancy is surgical resection. And if we're creating these big ablative defects, we have to have something that we can put in there, which is really free tissue reconstruction. And I hope they showed you some of the defects that we create. We really can reconstruct almost anything. And so many of these tumors that couldn't really be treated with surgery prior to free tissue now are routinely treated with surgery because we have this great option that has better healing outcomes and improved functional outcomes as well. Here are references, and that's the end of my talk, and I will stop sharing my screen.
Thank you very much, Dr. Bell. So I will start my part. Let me see if we can share screen here. Okay. We're going to be short on time, so I will. How do I advance this one here? So as Dr. Bell mentioned, really for oral cavity surgery really is a primary modality. So for the most part, radiation for oral cavity cancer really is in adjuvant setting. So I'm going to talk about adjuvant radiation therapy a little bit and how we do it, why we do it, and is there anything we can do to reduce the toxicity or complications? Hopefully we can preserve patient quality of life. So as far as oral cavity cancer treatment guidelines, again, for early stage, surgery alone may suffice. For patients who cannot have surgery, the primary radiation therapy occasionally it can be used successfully. Now, for the most part, radiation therapies in adjuvant setting for large tumor, for patients with adverse factors such as positive nodes, PN9, perineural invasion, lymphovascular space invasion. Obviously, when patient has a positive margin and extranodal spread, the chemoradiation therapy would be necessary. So this actually shows the benefit of a post-op radiation therapy. If you focus on the bottom row here, so basically, I have a few literature I have to share with you in a minute, but this shows post-op radiation therapy versus surgery alone. For intermediate risk patients, the benefit is about 30% in disease-free survival and about 10% in overall survival. So really, there's potential survival benefit. Now, for more advanced stage cancer, high-risk patients, such as positive margin and E&E, or locally advanced stage, large T4. So the benefit of post-op radiation therapy is more profound, and 28%, almost 30% chance in overall survival benefit and 42% and 45% chance of better local regional control. So you see clearly, radiation therapy has a benefit. And so let's go over now. For low risk patients, surgery alone usually suffice. So, but the interesting thing is that how we select those patients is considered true low risk patients. So I'd like to share one study, which actually is the largest study looking at this aspect for patient has the clinically a T1, T2, and 0 disease, had a resection and a negative dissection. So the pathologically in 0 disease. So even for those patients, again, if there's any adverse features such as post-mortem lymphovascular invasion, peritoneal invasion, those patients actually will get radiation. So the group patient we're looking at the T1, T2, and 0 disease truly is low grade, low risk patients. But if you look at the low risk patients without additional treatment, so the risk of recurrence, the local recurrence is 10%, and 18% patient actually develop regional recurrent disease. And 1/3 patient actually one/3 patient recurred in contralateral neck. So that shows that for some patients, we really have to consider adjuvant radiation therapy, even they are considered low risk. So if you break down the study, really the patient has thicker tumors, especially thicker than 4 millimeter. So those patients have much higher risk for failure in the neck. And so those patients, we should consider adjuvant radiation therapy. Now move on to intermediate risk. So that is the T1, T2, and 1 disease. One patient has a single lymph node. Those patients can be observed, and also in general, we'll tend to recommend radiation therapy if there's any other features, intermediate features like peritoneal invasion, in addition to one single lymph node. But this is a study that came out about 2-3 years ago, looking at this T1, T2, and 1 disease group, which is intermediate risk. So the bottom line is that by adding radiation therapy, there's a significant benefit in terms of overall survival. So this is for patient has T1 and 1 disease. And if you look at patient at T2 and 1 disease, the survival benefit is even more profound. So both are statistically significant. So this shows the benefit of adjuvant radiation therapy, even in for low risk or intermediate risk patients. So the benefits of radiation therapy really is because improved the disease progression-free survival and overall survival. So how we should do it, radiation therapy. Now we know IMRT, which really is now standard modality, radiation modality for head and neck cancer. We know IMRT provides excellent target coverage and the normal tissue sparing. So the most important thing when we do IMRT really is how accurately we can define the targets. So if you miss any a disease, no matter how good the IMRT is, you're going to fail. And so we know there's actually quite a variation among physicians in defining head and neck cancer volumes, which is expected. So we do have guidelines to follow. This is the consensus from URTC, RTUG, and the GORTAC group. So they tell us how to define the regional disease, actually regional lymph nodes from level 1 through level 7. It depends upon the primary. So at different primary sites, you have to select the lymph node coverage differently. So one thing is sometimes we may struggle. So for smaller lymph node, whether we should consider add those lymph node to the GTV, the gross tumor target, so or not, or make this microscopic disease. In general, if a tumor is larger than 1 cm, or 1.5 cm for the level 2 jugular digastric lymph node, or sometimes you see a necrotic center or it's round a cluster, and so this lymph node, and even though PET is negative, but this lymph node shows some characteristic for pathologic lymph node, so we'll cover those as a gross target. Share one case, the patient T2 and 1 disease, the lateral oral tongue, So I had, as expected, the partial gastrectomy and lymph node dissection. This is what pathology showed. It's a put ST2 because 2.5 centimeter, the depth invasion is 10 millimeter, margins clear, but one single lymph node without ECE. So how I do it? So basically, we define the CTV, clinical target volume. CTV1 is considered a high risk area. So really is a surgical bed. So I define that surgical bed at first as a CTV. Then you define the CTV2, which is a high risk area around the tumor bed around CTV, and also ipsilateral neck. So this is considered as a CTV2. And then the contralateral neck is defined as CTV3. Oftentimes you have to expand the field to cover the surgical bed. This is surgical scar right there. So once you define the volume, then you can prescribe those differently. So for the high risk area CT1, you give 63 in 30 fractions. Then for the high risk neck, you give a 60 gray in 30 fractions. The contralateral neck is a 54 gray in 30 fractions. So you can see we can do dose painting. We can deliver those different dose to different areas depending upon tumor burden. So this is what we actually normally see as the final treatment plan. Look at dose distribution and also look at the normal tissue sparing. So this is the general definition of CTV1, CTV2, and CTV3, and also we add about 3 mm margin as PTV, planning treatment volume. What about the toxicity? This is the part we like to focus on. And we know radiation therapy is effective. Radiation therapy has a very good chance, especially for microscopic disease, we have a very good chance to eradicate microscopic disease. But unfortunately, radiation therapy has significant side effects, especially for head and neck area. Acute toxicity, unfortunately, is not avoidable, like radiation dermatitis and mucositis. But oftentimes, that's transient, and it will go away after you're done with radiation therapy. Now, late toxicity is something we try to minimize, such as xerostomia, for instance, dysphagia. We have next talk actually specifically on dysphagia, the dental decay, fibrosis, and also complications such as radiation, the osteoid necrosis, radiation neuropathy, brachial plexopathy. The worst case will be spinal cord injury, and also radiation infection on carotid can cause stenosis and can cause a stroke. So that's complication. We have to try everything we can to minimize. So what are those factors for radiation toxicity? We know the radiation dose matters, right? The higher dose, the higher risk, and also fractionation, how much dose we give each time, and the radiation field size, radiation volume. So those are major risk factors, I should say major factors for radiation toxicity. And then also there are patient-related factors such as a smoking history. We know patient has has a significant smoking history. Those patients at a higher risk for radiation complications. Diabetic patients also has higher risk, and a certain genetic syndrome can increase the risk of radiation complication. And also normal tissue sensitivity, radiosensitivity. Some tissues are more resilient, more resistant to radiation than others, but some tissues are highly sensitive to radiation. Obviously, the most critical structure for head and neck cancer radiation treatment is the spinal cord, and so that's and of course optic nerves. If optic chiasm, those areas are very vulnerable to radiation. So of course, if a patient is getting concurrent systemic therapy, those patients also may be at high risk of acute radiation complications. Now, the simplest way and the most important way really to minimize toxicity and complication is to deliver radiation with a precise targeting, and also the timing, and to avoid unnecessary overtreatment, especially if you can avoid treating large volume or higher dose. You should do that, provided you're not going to compromise the chance of a cure. So a couple of examples show the better radiation technique does improve the better outcome in terms of functions, quality of life. One thing is to look at the carotid. So basically, this study look at the IMRT versus 3D, and clearly, the IMRT has a much better chance to spare parotid, even in long term. And so this is also look at the radiation fibrosis. So clearly, if you can do more normal tissue sparing with IMRT, you have a much better chance to avoid or minimize severe fibrosis after radiation therapy. So what about post-radiation dysphagia? This is a major problem we're facing, because nowadays we have a lot of HPV patients that are young, they're healthy, they have a highly curable disease, they're expecting, and we're talking about the expected survival is decades and decades. So that's why the long-term effects of radiation therapy, especially on patient functions, quality of life, is very important. One major thing is dysphagia. I know Carol actually will be talking about dysphagia post-therapy, not only necessarily radiation, but therapy as well. And also, there's a study looking at the what affect patient the most in terms of quality of life. Turns out the dysphagia is more important than xerostomia and more important than radiation fibrosis. So how can we reduce the risk of radiation-induced radiation-induced dysphagia? Really is a strong correlation between the dose and also the pharyngeal stricture muscles. And of course, the dose to the larynx, esophagus are also very, very important. So important thing is that you try to minimize radiation dose, such as mean dose to the larynx to less than 50 gray, and the mean dose to the pharyngeal stricture muscle to less than 50 gray, because nowadays we use a 45 gray mean dose. And also you look at the 50 and the volume receive 50 gray, 55 gray, 60 gray. So bottom line is that if you can, you really should try everything possible to minimize radiation dose to the pharyngeal strictures. So if you look at the current clinical trials, that tells you how to prioritize your volume when you do IMRT. So obviously, spinal cord has the highest priority, brainstem has the highest priority, then the treatment target. But the pharyngeal, the constrictors really has a very high priority. It's number 6, even higher than esophagus, higher than parotid. And so which means that you really have to try everything you can to spare the pharynx. So the dose now we use the 45 gray, and also you try to avoid high dose to the larynx at the same time. So this is what I do. Obviously, you outline the constrictors all the way from oropharynx to hypopharynx there, and also you contour the larynx. So try to spare that both structures as much as you can. So when you have a radiation apply, you can see how well you spare the constrictors, how well you spare the larynx. So make sure you can protect those structures to minimize radiation induced dysphagia after therapy. One thing I also want to mention is the technique. Let's say do radiation therapy for oral tongue cancer, for oral cavity. The bite block actually is very important. You use bite block to displace the tongue, displace the jaw away from the hard palate. So this will, when you do the radiation, you can substantially minimize radiation therapy to upper oral cavity, reduce not only potential long-term artifacts, but also acute side effects such as mucositis. So another thing is that when we do the planning, oftentimes we see a lot of metal scattering because of dental filling there. So with the new software, we can reconstruct it, the CT scan, to clean up the scatter effect, and it's a bit easier for target delineation. So this is a very interesting case. I mentioned the patient may have dental fillings there and the crowns there. So that really scattered radiation can cause substantial focal radiation mucositis, like this case, because dental filling. So how we avoid that? We know the radiation scattering doesn't travel very far. So if we can create some space, small space between the teeth and the cheek, or between the teeth and tongue, you can actually substantially reduce the scatter effect. So one thing I would do is use. Most patients will have a fluoride tray made by by our dental oncologist to apply fluoride after radiation. So that tray is quite thick. So you can ask patient to wear a fluoride tray for the radiation treatment. So you can see this patient has quite a bit dental. This is his dental artifact. You can see with the fluoride tray, you can create the space and to really minimize the radiation scattering to the buccal mucosa and even to the oral tongue because you can see the space there. So your patient has a fluoride tray, your patient has an extensive dental metals or fillings there. It's always better as patient to wear the fluoride tray to cut back scatter. So this patient, see without fluoride tray, you don't see the space. So this actually is very helpful to reduce acute mucositis. So in summary, we know adjuvant radiation therapy really is important in management of oral cancer, oral cavity cancer, actually head and neck cancer. So MRT really is the standard and preferred form of radiation for all head and neck cancers. It is important to be able to precisely define the targets and also to be able to define the critical structures to spare. So I really think it's important to introduce more stringent dose constraints for normal tissues of interest, such as the parotid, the larynx, pharyngeal stricture, which may eventually lead to less late toxicity. So that's my presentation. So our next speaker is Carol Gabler. She is actually